So picture this. You're sitting in a high-end medical spa, right? You've got your intake paperwork in hand, and you are finally taking some time out for yourself.
Oh, yeah, everyone knows that exact feeling. The clipboard, the waiting room.
Exactly. And you've been reading up on the O-shot, this really popular regenerative treatment for sexual wellness, and you're just ready to move forward. So you reach the medical history section, and you check this one specific box indicating a history of a pelvic mesh sling.
Right, just being honest on the form.
Yeah, exactly. You hand it back. But a few minutes later, the clinician returns, shakes her head, and just turns you away.
Which is incredibly frustrating.
It's devastating. You're told your surgical history makes this wellness treatment, far too dangerous to perform, so you leave the clinic feeling totally defeated. But, and here's where things get really interesting, what if that exact same forbidden treatment is currently being used by top urogynecologists to actually cure the complications of your synthetic mesh?
I mean, it creates this massive diagnostic paradox for patients. Because on one side of the medical community, the treatment is totally locked away. It's behind these strict exclusion criteria.
Right.
But then on the other side, you have these specialized surgeons actively using it as a breakthrough intervention to salvage failing implants.
So the core question for our deep dive today is this: can an O-shot be safely performed in patients who have a history of pelvic organ prolapse repair using synthetic mesh slings?
Yeah.
We are definitively answering whether this combination is a ticking time bomb or, just a massive medical misunderstanding.
And we have a pretty dense stack of sources to get through to answer this today.
Oh, yeah, we do. So what exactly are we looking at?
Well, we're looking at the official FDA safety communications regarding surgical mesh, alongside the current ACOG and AUGS clinical guidelines.
Got it.
And we are contrasting those with the really strict inclusion and exclusion criteria from ongoing clinical trials. Specifically, there's this 2026 trial examining PRP for genitourinary syndrome.
Which is going to be a huge piece of this puzzle.
Absolutely. And most importantly, we are diving into specialized urogynecology research out of Flinders University in Australia and also the University of Indonesia. And I'm telling you, this research completely rewrites our understanding of tissue healing around synthetic implants.
Okay, so we should probably start with the implant itself, right?
Okay.
Because going through these sources, it becomes immediately apparent why a med spa would just panic when they see the word mesh.
Oh, completely. The stigma is huge.
Yeah, and it's driven largely by the FDA's 2019 order, right? The one where they halted the sale of transvaginal synthetic mesh for pelvic organ prolapse.
Right. And we really have to unpack the mechanics of that ban because honestly, the headlines at the time created a lot of confusion.
I remember the commercials on TV. If you or a loved one had mesh in.
Yes, exactly. The lawsuit commercials. So our listeners are likely familiar with pelvic organ prolapse, or POP, and stress urinary incontinence, which we call SUI. So for years, surgeons were using the synthetic polypropylene mesh to structurally reinforce the failing pelvic floor. Basically, when organs like the bladder or uterus are descending, which, by the way, is graded on a scale from stage 0 to stage 4.
And stage 4 is complete aversion, right?
Yeah, and unfortunately, it's
Yeah.
very severe. So by 2019, the data on transvaginal placement for POP was looking really alarming. The sources show an 11% risk of mesh erosion.
Which means what exactly?
It means the plastic essentially wears right through the vaginal wall.
Oh, wow.
Yeah, it's terrible. And along with that, there was a 9% rate of dyspareunia, which is severe pain during intercourse, plus all these chronic infections.
So, the natural assumption when you hear statistics like that is just that the material itself must be toxic. That the human body just rejects polypropylene outright. But the FDA didn't actually ban the material, did they?
No, they did not. And this distinction is so critical for anyone out there listening who might have a mesh implant. The FDA order explicitly targeted transvaginal mesh used for POP. It did not ban the exact same synthetic mesh when it's placed abdominally. That procedure is known as a sacrocolpopexy.
Right, so it's the exact same plastic.
Exact same plastic. And it also didn't ban midurethral mesh slings, which actually remain the gold standard today for treating stress urinary incontinence.
Wait, so if the material is exactly the same, why does the entry point matter so much?
It really comes down to biomechanical load and the surgical environment. So the vagina is what we call a clean contaminated field.
Meaning it has its own microbiome.
Exactly. It's naturally populated with bacteria.
Right.
So when surgeons were placing these really large pieces of synthetic mesh through an incision in the vaginal wall to support the heavy, constant downward pressure of prolapsing organs. I mean, they were asking a lot of the tissue.
Yeah, that makes sense.
The sheer stress on the vaginal mucosa over time, combined with the non-sterile placement, it just led to tissue breakdown.
Okay, so if I'm understanding this right, it's like recalling a specific faulty brand of tires because they consistently blow out on the highway under heavy loads.
That's a great way to look at it.
But the concept of tires themselves isn't banned. It's just about how and where the mesh is placed. So the smaller mid-urethral slings are operating under completely different physical mechanics.
That analogy tracks perfectly. A midurethral sling is a much, much smaller piece of mesh. It acts as this sort of tension-free backstop for the urethra during moments of sudden abdominal pressure.
Like coughing or sneezing.
Right. Or laughing, jumping on a trampoline.
Yeah.
It isn't bearing the constant heavy weight of a descending uterus or bladder. So because of that difference in biomechanical stress, the midurethral slings actually have a highly successful safety profile.
Okay, so we've established that a midurethral sling or an abdominal mesh is a standard, completely safe medical implant. Yet when you walk into a cosmetic clinic requesting an O-shot, that safe implant triggers an immediate hard rejection.
Immediate.
So let's look at what the O-shot actually is, mechanically speaking, to figure out why providers are so terrified of mixing the two.
Right. So the O-shot utilizes platelet-rich plasma, or PRP. Now, it is an autologous therapy, meaning it is derived entirely from your own blood.
Nothing synthetic.
Nothing at all. A provider draws a small amount of your blood, they place it in a centrifuge, and they spin it at a really high velocity.
Which separates everything out.
Exactly. It separates the red blood cells from the plasma, and that allows the provider to isolate this one specific layer of plasma that contains a heavily, heavily concentrated volume of platelets.
See, when I think of platelets, and I think most of us are in this boat, we just think of the cells that clump together to form a scab when you get a paper cut.
And honestly, that was the prevailing medical consensus for a really long time. But in 1974, researchers Kohler and Lipton made this pivotal discovery.
What did they find?
They found that platelets don't just act as physical plugs. They are actually packed with active granules that secrete powerful growth stimulants.
No.
Yeah. When platelets are activated at a tissue site, they degranulate. They release this massive payload of cytokines and growth factors, like vascular endothelial growth factor, or VEGF, and platelet-derived growth factor.
So these growth factors, they are essentially the chemical messengers that tell the local cells to kick into overdrive.
That's exactly what they do.
They trigger the formation of new blood vessels, new collagen, new nerve endings in the injected area. So in the context of the O-shot, this concentrated plasma is injected into the anterior vaginal wall and the clitoris to regenerate tissue, improve natural lubrication, and enhance sensitivity.
Oh, yeah, you got it.
It's literally using the body's own biological hardware to rebuild the area.
Exactly. And because the material is entirely autologous, I mean, the risk of an allergic reaction is practically non-existent.
Right, because it's you.
It's you. It doesn't carry the risks associated with, say, synthetic dermal fillers or foreign pharmaceuticals.
Which makes the exclusion criteria in our sources so baffling to me. I mean, I'm looking at the strict guidelines for standard medical spas and even the protocols for upcoming, highly controlled clinical trials.
Yeah, the rules are rigid.
Like, there is this 2026 trial listed on clinicaltrials.gov, and they are investigating PRP for genitourinary syndrome. But under their exclusion criteria, they explicitly list any patient with a, quote, history of prior vaginal mesh or midurethral mesh sling surgery. They treat a prior mesh implant as a hard disqualifier.
It is a pervasive rule across both commercial wellness and clinical trial protocols. The general feeling is if you have the plastic in your pelvis, you cannot have the plasma.
Okay, but wait, let's unpack this. I really need to challenge the underlying logic here. If PRP is literally just a concentrated serum of your own healing factors, why on earth would a mesh sling disqualify you? Is the assumption that injecting your own plasma is going to hyperstimulate your immune system and cause it to suddenly attack a dormant mesh?
That is precisely the assumption driving these protocols.
Really?
Yeah, many practitioners fear that heavily stimulating the tissue immediately surrounding a synthetic implant will trigger or exacerbate an immune flare-up.
Okay.
To understand their fear, we really have to look closely at what happens on a cellular level when you introduce a synthetic plastic into the human body.
The foreign body reaction.
Yes, the foreign body reaction. The moment a polypropylene mesh is implanted, the immune system detects it. It's foreign, so the body sends in macrophages.
Right, which are a type of white blood cell, yeah.
Exactly. Their primary job is to engulf and digest cellular debris and foreign invaders. But, and here's the problem, a macrophage cannot digest a piece of plastic.
No, obviously not.
So when they fail to break it down, they undergo what we call in medicine frustrated phagocytosis.
Frustrated phagocytosis, I love that term. The cells are literally exhausting themselves trying to eat something indestructible.
They are. They're trying their hardest. And when they finally realize they can't clear the plastic, the macrophages actually fuse together.
Wait, they merge.
They merge. They form these massive structures called foreign body giant cells.
Oh, wow, that sounds a little terrifying.
It's just the body's defense mechanism. But these giant cells then signal fibroblasts to flood the area. And the fibroblasts begin laying down this thick, rigid collagen, effectively trying to build a scar tissue wall to quarantine the mesh from the rest of the body.
Okay, so the implant is basically permanently encased in this state of chronic low-grade warfare. The immune system never actually stops fighting it.
Correct. The area becomes locked in chronic inflammation. And over time, that thick scar tissue can contract and shrink, and that pulls on the surrounding nerves.
Ouch.
Yeah, this is the exact mechanism that leads to the chronic pelvic pain, the painful intercourse, and the mesh erosion we see in the complication cases. The tissue breaks down because the chronic inflammation just degrades the healthy mucosa over the mesh.
Okay, so looking at it from that angle, if the tissue is already in a state of hypervigilance, I can totally see why a wellness clinic wouldn't want to inject a massive concentration of cellular stimulants into the area.
Right, it seems risky.
That sounds like throwing gasoline on a fire. But here is where the sources take a massive turn. You look at the cutting-edge urogynecology research, and they aren't avoiding PRP. They are deliberately injecting it into the most severe mesh complications.
The paradigm shift here is just profound. Let's look at that longitudinal study out of Flinders University in Australia. This ran from 2013 to 2024.
That's a long study.
11 years of data. And this wasn't a study on healthy women looking for sexual wellness. They followed 47 women, average age around 64, who had highly symptomatic vaginal mesh complications.
So we are talking about women who already had mesh erosion. The plastic was literally exposed and protruding through the vaginal wall.
Yes, exactly.
Usually at that stage, the only option left on the table is a complex, highly invasive revision surgery to just cut the mesh out, right?
Historically, yes, that was the only path forward. And revision surgery is incredibly difficult because you are trying to cut plastic out of dense, inflamed scar tissue, and it's sitting right near the bladder and the bowel.
The surgical risks must be severe.
They are. But the researchers at Flinders wanted to see if the growth factors in PRP could modulate the immune response instead of just stimulating it.
Okay.
So they injected PRP directly into the affected, eroded vaginal tissue, often pairing it with a fractional CO2 laser to stimulate the mucosa.
Wait, hold on. You're telling me that a piece of permanent synthetic plastic that is actively eroding through human tissue can just be healed over?
Yeah.
Just by injecting some concentrated plasma?
I know it sounds wild.
It sounds way too good to be true. How does the body not just continue to recognize the plastic and fight it?
Because the PRP changes the chemical instructions being given to the immune system. We talked about macrophages earlier.
Yeah, one's doing the frustrated eating.
Right. Well, macrophages actually exist in different states. The M1 state is pro-inflammatory.
Right.
Those are the cells attacking the mesh and causing the chronic inflammation.
Okay.
But there is also an M2 state. M2 macrophages are anti-inflammatory. Their entire job is tissue remodeling and repair.
So the growth factors in the PRP act like a biological override switch. They're signaling the macrophages to switch from the aggressive M1 state to the healing M2 state.
Exactly. The concentrated cytokines in the PRP tell the immune system to stand down. They signal the fibroblasts to stop laying down rigid scar tissue, and instead, they start building healthy, pliable collagen and new blood vessels.
That is incredible. So what happened to the women in the study?
The results from the Flinders study are staggering. Over an average 12-month follow-up, 85% of these women avoided revision surgery entirely.
85%.
85%. The PRP stimulated their own tissue to completely heal over the exposed mesh.
Wow.
Their mucosal integrity was restored, their bladder and bowel functions improved, and their chronic pain was significantly reduced.
So it's like using fire to put out a fire.
Yeah.
The local med spa says, we can't give you an O shot because you're mesh, but The leading urogynecologists say we're going to inject this PRP specifically to heal your mesh.
Exactly. PRP wasn't a danger to the mesh. It was the mechanism that finally forced the body to accept it.
That completely flips the script. I mean, the commercial clinics are assuming PRP will cause an immune system overreaction. But the clinical data proves it does the exact opposite. It mediates the immune response.
Yep.
And this leads us to the 2024 case series out of the University of Indonesia, where they're taking this concept even further.
Yeah.
Because they aren't just using PRP to fix failing mesh, they're using it before the mesh is even implanted.
Right. The Indonesian study is a fascinating glimpse into the future of regenerative surgery.
Yeah.
The researchers there were dealing with complex multi-compartment pelvic floor reconstructions.
These are severe cases.
Very severe. These are patients with stage 3 and stage 4 prolapse, meaning their organs are protruding significantly outside the body.
Oh, that sounds so incredibly difficult to deal with.
It is. So because of the severity of the prolapse, these patients require a transobturator tape, what we call a TOT mesh sling, to support the urethra, alongside extensive native tissue repair. But the risk of mesh erosion in these complex, heavy load cases is incredibly high.
So to preempt the foreign body reaction we talked about, the surgeons developed something called PRP days. What exactly is that?
PRP DES stands for platelet-rich plasma decellularized amnion scaffold.
Okay, that's a mouthful. Break that down for us.
So the surgeons take a standard piece of synthetic TOT mesh, and instead of just implanting the bare plastic into the tissue, they sandwich it inside a biological coating.
Like a protective sleeve.
Kind of, yeah. They use an amniotic membrane scaffold. Now, this material is highly prized in regenerative medicine for its tissue-building properties. And they take that scaffold and they soak it in the patient's own heavily concentrated PRP.
So they are essentially giving the mesh a biological diplomatic passport.
Oh, I love that phrasing. Yes.
By coating the plastic in the patient's own growth factors and this amniotic tissue, the immune system sees it as a friend rather than a foreign invader when it enters the body.
That is the exact mechanism they are aiming for. The amnion scaffold itself is known for being immune privileged.
Meaning what exactly?
Meaning it naturally suppresses immune rejection. So when you combine that with the M2 stimulating cytokines from the PRP, you are chemically instructing the surrounding tissue to integrate with the implant immediately. You're just skipping the inflammatory phase altogether.
That is genius. And what were the clinical outcomes of giving the mesh this, diplomatic passport?
Well, at the 3-month follow-up for these highly complex reconstructive patients, the surgeons reported a complete cure of their stress urinary incontinence.
That's great.
But more importantly, the patients had optimal mucosal healing, 0 reported pain, and absolute 0 mesh exposure or erosion.
Wow.
Yeah. By the time the body's immune system encountered the synthetic material, the local environment had already been programmed for acceptance and integration.
It's incredible, really. But, it brings us right back to the listeners sitting in the waiting room of the medical spa, holding a clipboard, feeling entirely defeated.
Right, back to reality.
Right. If the science unequivocally shows that PRP stabilizes and heals the tissue around a synthetic mesh, why did the clinician just turn them away? Let's get to the practical verdict here. If you have a midurethral mesh sling or an abdominal mesh, can you get the O shot?
The answer is a definitive yes, but it is heavily conditional on who is holding the needle. We really have to separate the cutting-edge surgical science we just discussed from the realities of a commercial clinical setting.
Because if you go to a standard cosmetic spa, a pop-up wellness clinic, or even a general practitioner who just offers the shot on the side, they are operating under very strict generalized liability protocols.
And honestly, from a medical standpoint, they absolutely should be. A cosmetic clinician or a general nurse practitioner is not equipped to evaluate complex pelvic floor dysfunction.
Right, it's not their specialty.
Exactly. So if you check the box indicating a history of pelvic mesh, they are legally and ethically obligated to assume the worst-case scenario.
Better safe than sorry.
Exactly. They don't have the specialized training to know if you have an active silent pelvic infection. They cannot assess if you have an undiagnosed prolapse that is putting shear stress on the vaginal wall.
And most importantly, they don't have the diagnostic tools. A medical spa cannot perform a cystoscopy to look inside your bladder.
No, absolutely not.
Or run urodynamic testing to ensure that your mesh hasn't silently eroded into your urethra over the past 5 years, they are essentially flying blind.
Exactly. Injecting PRP blindly around an unevaluated synthetic implant is a massive liability. If the mesh is already quietly eroding and they perform an injection, any subsequent pain or complication will immediately be blamed on their procedure. Turning you away is their only defense mechanism.
But the narrative changes entirely if you seek out a specialized urogynecologist, like a provider who is board certified in female pelvic medicine and reconstructive surgery.
The difference in capability is night and day. A urogynecologist is an expert in the physics of your pelvic floor. When they look at your medical history, they know exactly what type of mesh you have, the specific vector forces it relies on, and precisely where the surgical anchors are placed in your tissue.
They aren't guessing. To them, the O-shot isn't just an off-the-menu cosmetic upgrade for sexual wellness. They understand it as a targeted, regenerative medical therapy that interacts with your specific anatomy.
Absolutely. According to specialized clinical protocols like those published by the Coyle Institute, a urogynecologist can safely perform a PRP injection around a patient with a midurethral sling.
Because they know what they're looking at.
Right. They know how to map the tissue, they understand the nerve pathways, and they know exactly how deep to inject to stimulate the mucosa without disturbing the structural integrity of the mesh anchors.
And the irony is, for patients who do have lingering low-grade discomfort from their sling, maybe some tight scar tissue or minor nerve irritation, the urogynecologist might utilize the O-shot specifically to relieve that chronic pain.
Exactly. Utilizing the exact same M2 macrophage switch we talked about in the Australian study.
That is the ultimate takeaway here. The safety of the procedure isn't dictated by the presence of the mesh. It is dictated by the diagnostic capability of the provider,
Spot on.
which means the burden of navigation really falls on you. You have to be the CEO of your own body.
You really do.
You cannot just accept a flat no from a local wellness clinic as the final, unchangeable medical truth about your anatomy. If you have an implant, you need to know exactly what it is. Is it a midurethral sling for incontinence, an abdominal sacrocolpaxy, or is it an older transvaginal POP mesh?
Having that specific medical literacy is crucial because once you know your own surgical history, you can advocate for yourself by seeking out a specialist who actually understands the molecular biology of your tissue.
Rather than a clinician who is just forced to follow a commercial liability checklist.
Exactly.
We started this deep dive looking at a treatment that the beauty and wellness industry treats as completely forbidden for a huge demographic of women. And just by examining the actual cellular mechanics, we uncovered that top-tier surgeons are using that exact same plasma injection to cure the most complex complications of synthetic implants. The treatment didn't change, the medical understanding did.
It really highlights how slowly commercial medicine adapts to regenerative science, and it leaves us with a fascinating thread to pull regarding the future of medical technology.
Oh, definitely.
Today, we focused entirely on the pelvic floor. It's a highly dynamic, highly sensitive region of the body. But if a targeted injection of concentrated autologous blood can successfully teach the immune system to peacefully accept a synthetic plastic mesh in that environment, well, the broader implications are staggering.
You're thinking about the applications outside of urogynecology.
I am. Think about every other medical implant we rely on in modern medicine.
Like what?
We are talking about pacemakers, artificial knee and hip joints, breast implants, spinal hardware.
Oh, wow, yeah.
The failure rate and the chronic pain associated with all of those devices are almost entirely driven by the exact same foreign body reaction.
It's the same process everywhere in the body.
Exactly. The immune system attacking the metal or the silicone, the fibroblasts laying down rigid scar tissue capsules, the chronic inflammation.
If the PRP DACE methodology from the Indonesian study can be generalized, we could be looking at a future where every single implant is given that biological diplomatic passport.
Exactly. Could this autologous biohacking using our own concentrated plasma as a universal biological coding be the key to making all medical implants completely complication-free?
That is wild to think about.
We might be standing at the very beginning of the end of the foreign body reaction as we know it. Our own blood could become the universal peacemaker between human biology and synthetic medical technology. It is certainly something to think about.
That is an incredible thought to leave on. The idea that the key to integrating the most advanced synthetic hardware lies entirely in our own plasma. Well, that wraps up today's deep dive into the O-shot, pelvic mesh, and the absolute frontier of regenerative healing.
It's been a great discussion.
The next time someone tells you your medical history permanently disqualifies you, remember to look at the science behind the protocol. It might just mean you haven't found the right specialists yet. Keep questioning, keep exploring the mechanisms of your own anatomy, and keep being the CEO of your own health. We will catch you on the next deep dive.